Greetings, class! Another drug to go over today, and this is kind of a big one, especially if you've got a nice racing heart. This is the drug you want to go to, which is Diltiazem. And there's some dangers to giving Diltiazem. We're going to talk about those real quick. But again, in Diltiazem, it's kind of more commonly called Cardizem, and it slows down the electrical conduction, especially through the AV node. So it's used to slow down those heart rhythms. Extremely effective in both atrial flutter or AFib with a rapid ventricular response, because again, it slows down the calcium channels. So it slows down that time of repolarization. And again, so this is a calcium channel blocker, also known as a class 4 antidysrhythmic drug. Not to be confused with a benzodiazepine. This is a benzothiazepine. So again, it has a little bit different chemical structure than that. Don't get confused by that. But it is also an antihypertensive agent. They like to use this one a lot for controlling blood pressure, especially because, again, it slows down the heart rate, and therefore it kind of slows down the force of contraction. So again, it blocks calcium channels, so it slows down the heart rate. But it also does a little bit of myocardial contractility reduction. Remember, calcium is one of the big ions that's used for muscles in the contraction phase. So it can reduce the squeeze of the heart just a little bit. So again, when we give this drug, it's usually, the onset is about 2 to 5 minutes. And one thing I will also say about this drug is this is one of those drugs you absolutely do not give fast. You want to give it slow. So again, the duration of action is usually around 1 to 3 hours. So again, when we're administering it, we'll talk about a little bit of administration a little bit later of how to administer it. And we'll talk about the common ways that paramedics do it versus the common ways that they probably should be doing it. Now, AFib or A-flutter is our indication for this, or if you've got SVT that does not work with traditional therapy. Again, most of the time we're going to use adenosine first, which is going to essentially do a chemical reset of the heart, and we can either slow it down to see if they've got AFib or A-flutter. So again, but it does work very well on SVTs, or multifocal atrial tachycardia works very well on them. So some of the side effects, again, they'll get really sensitive to light. They may actually see double vision, and they will complain of ringing in the ears. That's kind of a really common one that happens with those. Again, your AV block, the problem with giving this drug is that it's designed to slow down conduction through the AV pathways. The AV node, the bundle of His, it slows all of that conduction down, which can unfortunately bring about bradycardia, first-degree blocks. It can exacerbate CHF, definitely will drop the blood pressure on you. And it's kind of either the side effect here is what kind of causes this one right here. So what happens is the heart, it slows down the signals through that AV junction, and as it slows them down, the ventricles kind of go, hey, I want to beat faster. And so it kind of sends it into a ventricular tachycardia sometimes. Again, it can cause a little bit of shortness of breath. Again, usually because of the blood pressure changes, you get the vomiting. It can constipate somebody. And the other extreme is also possible with this. You get a lot of flushing too when you give this drug, so be aware of it. If they have a slow heart rate, do not give them Cardizem. Do not. The other one is we absolutely don't give it is Wolff-Parkinson-White, WPW. And the reason is because we really want to stop that using another means, and we usually use either a beta blocker or the adenosine to stop the Wolff-Parkinson-White from recirculating. And again, if you remember, Wolff-Parkinson-White has the extra pathways between the atria, they're actually the ventricle to the atria, which causes a loop of electricity to happen. But again, if we use it on the Wolff-Parkinson-White or any type of short PR syndrome, we can cause them to actually go into a systole. So really be careful when you're giving that. Do not give it for WPW. Again, we don't want to use it in VTAC cases. Again, we have other treatments that we want to use during VTAC. Again, don't give it with Lasix, because if you give it with Lasix, it's going to form a nice, lovely crystal, and we don't want that to happen. any of the protease inhibitors, again, it can increase the actions and the side effects. And again, if you give it with amiodarone, digoxin, any of the antidepressants, it can cause effects on the heart. So if they're already on a medicine, especially amiodarone and dig, you really want to be careful when you give cardizem to these patients. And by the way, usually you don't see patients that are on long-term amiodarone and digoxin in some sort of SVT situation. Usually you don't see that. I would be looking for another cause at that point. Again, benzos, beta blockers, the big ones there, they can increase the rest of the side effects, and some of which of those can be really potentially life-threatening, so you really got to be careful with these drugs on that. Do not administer this with, let's say, a sotalol or a metoprolol. If they're on beta blockers, you got to really be careful, but if you are the one giving the beta blocker, probably shouldn't be giving it alongside a calcium channel blocker. You're going to get severe bradycardia if you do that, so don't do it, okay? And again, the half-life may be increased for geriatric patients. Again, it's metabolized in the liver. They have a decreased hepatic function. Probably not going to do good. Now, we usually store this drug in the refrigerator. And if you don't do it in the refrigerator, that's okay. It's good for about a month outside the refrigerator. But once after a month, you really need to get rid of it. The cost effect of the drug, usually they won't, if you don't have a unit with a refrigerator in it, they usually, again, they after a month, it's a very low cost drug, so they simply throw it away. Remember that if you get PVCs, if you convert SVT with it, every now and then they'll start throwing PVCs on you, so also be careful of that. 0.25 milligrams per kilogram, and it says over 2 minutes. I would say go slower. And the reason I say that, number one, they're stable. So if we're giving this drug, they're a stable patient. So give it slow. As a matter of fact, there's a lot of people draw it up in a syringe and give it that way. I prefer to push this into like a 250 bag and whatever that medicine is, and then I run it in. I use a 60 drop set, and I might run it in wide open. But by doing that, it slows down the administration to around 4 to 5 minutes. By the way, if I get their heart rate where I want it, I can just simply turn off the cardizem drip, and then they're okay. And then I chart how much I gave, and then if they start to speed up, then you can open it back up and give them the remainder of it. So be careful, in especially if you're doing a push of this drug. Make sure you're doing it with a lot of volume, 10 to 20 cc's of flush in your syringe. Don't just squish this drug out quick. You're looking for trouble when you do that. And the biggest one that you're going to get in trouble with is that it can cause VFib, especially when you give it fast. So anytime you're giving any calcium channel blocker, give it slow. And again, we usually don't use it for pediatric patients. Again, it's IV push or IO, and most of the time, again, we give it IV push. And again, it can cross the placental barrier, so it can cause some problems with the fetus. So just be aware of that. But I have had some patients where they were really pregnant and really having a problem, and then had to give the cardizem in order to slow their heart rate down because they were in SVT. Kind of a freaky thing that happens. With that said, that's the end of the cardizem. Again, I can't stress enough, push it slow. Any calcium channel blocker, push it slow. VFib is the result if you don't. So be careful, guys, out there, and we will talk to you next time.